Hello, everyone. My name is Anthony Tioli. I'm a physiotherapist in private practice in Rosemere, Quebec, in Canada. And I'm also the president and founder of Info Physiotherapy. Today, I'd like to do a short 5-minute video summarizing a blog that I wrote in collaboration with BF Formation. And this blog article was on clinical classification criteria for knee osteoarthritis. So a lot of people don't know that a radiograph or an X-ray is actually not required for the clinical diagnosis of knee osteoarthritis. A clinical diagnosis can be made using the patient's age, symptoms, and clinical findings. With respect to clinical classification criteria for knee osteoarthritis, there are typically three. The first one is the NICE guidelines, and they state that a diagnosis of OA can be made without imaging if a person is 45 years of age or older, has activity-related joint pain, and has either no morning stiffness or morning stiffness that lasts 30 minutes or less. If you take a look at the EULAR guidelines, they state that a confident diagnosis of knee OA can be made without an X-ray if an adult above the age of 40 years old has usage-related joint pain and short-lived morning stiffness and functional limitation, and one or more of the following: crepitus, restricted movement, and bony enlargement. The third and final guideline is the Acr Guidelines, which state that a patient with knee OA should have knee pain and 3 or more of the following 6 criteria. So above 50 years of age, morning stiffness less than 30 minutes, crepitus on active movements, tenderness of the bony margins of the joint, bony enlargement, and no palpable warmth. So the next question you might be wondering is one of them best? Out of the 3 that we have, is there one of them that is best for making the clinical diagnosis of knee osteoarthritis? So there is one study that was published in 2019 that compared the 3. It's a cross-sectional study of about 13,500 patients with knee symptoms or functional limitations that were associated with osteoarthritis. And what they found was that 39% fulfilled all 3 sets of criteria, 48% fulfilled the EULAR criteria, 52% fulfilled the ACR criteria, and 89% fulfilled the NICE criteria. Then what they did is they took a subgroup of these patients with self-reported radiographic knee OA. So these were patients where they asked them, did you have X-rays of your knee in the last 6 months, more than 6 months ago, or not at all? And so the ones that responded yes, they had X-rays, were then asked, were there changes associated with osteoarthritis? And the ones that responded yes to that question were included in this group. And again, what they found was that about half fulfilled the EULAR and the ACR criteria, and 90% fulfilled the NICE criteria. So this essentially just tells us that the NICE criteria might be best, especially given that these patients were seen in primary care. So for patients with knee osteoarthritis consulting to primary care, the NICE criteria would seem to be most appropriate. Now, what are the clinical implications with regards to the clinical classification criteria? Well, the clinical diagnosis of knee osteoarthritis can be made only by a medical doctor. So that's not the point of this presentation is not for other healthcare professionals to be making the diagnosis. However, these criteria can be really helpful to help inform the clinical impressions of other healthcare professionals. They can also help to inform the subjective and objective exam. So for example, it can provide a healthcare professional with an idea of the key symptoms and clinical findings to look for that would be consistent with a clinical diagnosis of knee osteoarthritis. If you're interested in learning more, feel free to head to bfformation.com to read the full blog article.